Welcome to the Chromatic Connection, a space where vibrant minds collide and the hue of human expertise blend into something extraordinary. I'm your host, Fatma El-Shirawi, and every week we dive into a kaleidoscope of ideas, stories, and wisdom shared by top industry experts. Diverse minds meet and ideas shine in full color. This week, I have a very special guest who is going to teach us all about type 1 diabetes. How do we identify it? How do we take care of ourselves? And what do we need to know about the future? So the story with Dr. Milena is very special because she is one of the only doctors that I can say gave me back a normal life as a type 1 diabetic. So welcome, Dr. Milena. I am very happy to have you today on my podcast.
Thank you, Fatima. It's very special. Thank you for the opportunity and having me here.
Great. So today we're going to dive into a lot of questions I have for you. So
yes,
be ready.
Let's do it.
Okay. So, of course, the first question would be, how long have you been in the field of diabetic care, and what made you interested in specifically going into this specification of diabetic care?
Yes, good question. Well, I just want to add one thing before we start, actually, two things. First, all the things that we talk here cannot be taken as medical advice. People who are listening us, they need to search their specific physician. And also, I want to give a small gift before. It's a pancreas. It's from ADA. Are you put here?
Oh, that is amazing. Thank you. Oh, I'll be wearing it for sure.
Yes. So I was drawn to diabetes field since the beginning of the university, when I witnessed someone from my family, actually my aunt. She was struggling to control her glucose levels, and unfortunately she faced a lot of complications. And it's so interesting how I always think there is much more in the room to improve their patient's life, especially in my family, to make us there healthy. And dealing with chronic disease is challenging, but it's also very rewarding. So I'm happy that I decided to go for this field.
Yes. Usually, I've noticed, like, whenever somebody's passionate about something, it's a personal story or a personal experience that they have, that they become an advocate for such a thing.
You're right. Yes.
Yeah.
I remember in Christmas time, my cousins coming to home and complaining about my aunt. Oh, she's not eating correctly. You need to take care. So I always have this in my mind.
Yes. So now we'll dive into the technical part. So I have a lot of technical questions for you today. So first thing I want to ask is, what tests should be done to identify if you are diabetic? And also, what are the GAD antibody tests that is required?
Okay, good. So basically we have two types of diabetes. For type 1, majority of the patients, when they develop with symptoms, extremely thirst, losing weight, fatigue. And the cases, they go to the hospital and make the diagnosis inside the hospital with the glucose, with HbA1c, so in the blood tests. And to confirm the diagnosis of type 1, we need to have the antibodies. We have more than 9 types of antibodies. But anti-GAD is one of the main antibodies that blocks the pancreas and how the pancreas works. So blocks the insulin production by the pancreas. So we can check the antibodies in the blood, but anti-GAD is only one of many of antibodies. For other types of diabetes, gestation, and type 2, we have different tests. But we need to remember that type 1 can happen in any kind of age. We always think that type 1 is like a kid disease or from the teenagerhood, but no, even patients with 90 years old, 8 years old, they can have they can develop type 1.
Yes, that's correct. And that's what happened with me. I got it at a much later stage in my life. And for me, in terms of testing, it was that they told me I was insulin resistant. And then after, I did change my diet. I tried to stay healthy, but at the same time, sort of my stress level was high. So it started increasing. And this is where, honestly, I saw the gap and the difference between Glucare Clinic and how they approach testing and how your standard clinic. So in my case, for 4 years, because they did not do the antibody test, they did not identify me as a type 1. And it is very important that I feel that the antibody test must be done.
Yeah,
regardless of what type you would be, because at least you make sure you differentiate what you are.
Yes, the treatment is different. So, for example, in the clinic, we need to do this in the first visit.
Yes.
Along the HbA1c, the glucose, the antibodies must be there.
Yes, great. What phenomena are commonly associated with type 1 diabetes that you have observed in your practice?
Okay. Yes, this is very interesting also question because type 1 is a challenge and is a daily-based disease. Né? I say the patients, they cannot take vacation of type 1. Yeah. Each decision that you take, you need to think about diabetes. If you go to a restaurant, if you're going outside, depends of what you're going to eat, depends of the weather of the place you're going, the trips. So these fluctuations, from the glucose fluctuations the patients type 1, they face, in my opinion, what is the most challenging part. The hypos, almost 100% of the patients, they are afraid of the hypoglycemias. Yeah. Luckily, now we have all the technology, the sensors that we're going to approach later. But these fluctuations are very challenging. And some patients also, unfortunately, they face more severe complications, for example, DKA, the diabetes ketoacidosis. So we need to remember that the body doesn't produce insulin and starting to produce ketones to have energy. And this can develop a DKA. During over these years, I have been practicing more than, let's not put so much years, but at least 12 years. I see in my office also patients with burden of the disease. So the mental, the emotional burden to have in type 1. As I told you, to deal with taking many decisions during the day. How many insulin units of insulin the patient need to put, if they calculate the amount of carbs correctly. So this can, we call this diabetes distress. And I see this quite often.
And can you tell me also about the phenomena where your blood sugar goes up between like 2 a.m. and 8 a.m. to this phenomena?
Yes, interesting. Yeah. Yes, the down phenomenon. We have mainly two the phenomena, Somoji and down. But down phenomenon can happen when the patients in the morning, they release more adrenaline, cortisol, and can spike the glucose in the morning time. And the Somoji effect can happen because we, for example, patients, they have hypoglycemia during the night and the hyper as rebound because the body always tries to defend after hypoglycemia. No? So the symptoms, for example, of hypoglycemia, the patient starts shaking, trembling, sweating, is because of adrenaline released in the body. So this can cause, it's a defense of the body. So every time that we have lows, we have a defense. And this is common with type 1. So depends of the sugar at night, depends how was the sleep. We know nowadays that it's not just the insulin, but the lifestyle, the exercise, the food. So many decisions can interfere in the glucose level.
Right. Very interesting. So just to recap, so we have your hyperglycemia, which happens when you are exerting a lot of energy or you haven't had food for a long period of time, correct?
For example, fasting.
Yeah, from fasting. Yeah. And then we have the distress, which is when you are burnt out, correct?
Yes.
Yeah. And then we have the down phenomena, which we said what happens between 2 a.m. and 8 a.m. And this usually has to do with the level of insulin you have taken. Sometimes where it's not enough, so it goes
and also
high.
growth hormone. So we need to remember around in the morning 4, 6, 8 a.m. we release a natural, physiological, our body release some hormones, adrenaline, cortisol, growth hormone, and these hormones are contra-regulators insulin. So they block how our insulin works in patients with type 1. So we call this the status of more insulin resistance. So some patients, they need to take more insulin in the morning.
Mm-hmm. And can you explain also, for example, like when you do a high intensity, and this was something you taught me. I was under the impression, like, for example, if I do high cardio, my sugar would go low. So I would, like, for example, take an orange juice in case before. But then you explained to me that sometimes when you do a high intensity, it actually goes up and you need to take a correction before that. So can you explain more about that?
Yes. Look, type 1 and exercise, we can stay here until midnight talking because of depends the duration of exercise, the type of insulin that we do before, and also the food that if you're going to take before, for example, if you do exercise before or after the lunch or the dinner. But in general, aerobic exercise, for example, walking, running, swimming, they tend to drop the glucose. Every time that we move, especially the calf, the legs, these big muscles, they consume our glucose. For example, myself, when I use a sensor, sometimes when I run, my glucose reach 68. So because the muscles are consuming and takes this glucose from energy so we can do our exercise. But depends of the exercise, for example, lifting. We release more growth hormone, and this can contra-regulate the insulin, and we see in some patients high levels on the sensor. And also the muscles. If we have sensor here, for example, in the arms, we are moving, we are lifting the arms, we're going to see more glucose in this part of the body. We need to remember that levels of sugar for glucose we have in any kind of a liquid in your body. If we cry, we have a glucose in our tears. So, for example, in the past, the patients, how they were doing the diagnosis of diabetes, they have excess of urination and there's a lot of sugar in the urine. So they saw small, like ants in the urine. So we need to remember that the liquid of our body changes and the glucose changes in every moment of the day. So it's interesting for exercise. Patients with type 1 and pump, for example, they need to adjust the pump, the insulin pump, 1 hour, 1 hour and a half before. Or if you're going to eat after, the amount of insulin for your quick insulin needs to be less because you already have drop your glucose during the exercise. So you don't need a huge amount of insulin if you're going to eat close to the exercise. But luckily, as I told you, we have now tools, we have the sensors, we have different types of ways to deliver insulin, and we can monitor more this on real time when we can tailor the treatment. I think this is the most important thing for the last 10 years. Now, we have been using CGM at least 15 years already.
Yes, I think the CGM is the best invention ever.
Yes, because we are looking to have the watch, but until now we don't have it.
But so far, honestly, the CGMs that are around has really made life much easier, and definitely much easier in terms of even like taking your insulin, knowing when to correct it when necessary, so you avoid the spikes, which is great because usually these spikes is what our issue is, and we will be going further into how much damaging the spikes are.
Yes, sure.
Great. Please explain the medications available for managing type 1 diabetes and how do they work? What are the differences between them? So today you have brought us an example
Yes, I
So
brought a couple
I
of
want
points.
you to specifically explain, like, see, why I want to talk about this, because people have this misconception that there is one type of insulin for everyone, and people are also not aware that there is like the short insulin. They don't understand what the long the insulin is for. So if you can walk us through step by step.
Yeah, sure.
Yeah.
First, I'm going to start to explain how is our normal physiology of insulin production. So in one patient without diabetes, our pancreas produces insulin 24 hours, independently of what we are doing. If we are running, sleeping, talking, our pancreas produces a basal amount of insulin. Okay, and every time that we eat, of course, depends of the amount of food and the type of food, our pancreas produces these spikes of insulin to take this glucose from the food and carry on our body so we have energy. So this is the natural physiology. Patients with type 1, because of the autoimmunity blocks the insulin production, they don't have the basal insulin. So we need to do the same way out of the pancreas must do injecting the insulin. So we have a long-acting insulin nowadays. We have, for example, Tresiba, which is ultra long-acting, that lasts 24 hours. We have other long-actings, for example, Basaglar, Glargina, they last around 20 hours. So usually the patients, they take once to try to cover the whole day and the whole night. And for the meals, to cover the meals or to cover the snacks, we need to have the quick insulin. Nowadays, we have the ultra quick, the fastest insulin that usually start acting in 10-15 minutes and can last around 4 or 5 hours, depends of the patient. And the big challenge of the patients type 1 that I see this often is to put the insulin on time. Because, for example, if you're in a restaurant, the food's not there, or for example, for the kids, they don't know if the kid will eat the whole food. So this is the most difficult part for type 1. But